वो एक लेटर था.
Sorry, I didn't hear you, Saji. What did you say?
It's live, ma'am.
It's live. Over to Ganesh.
Yeah. Very good afternoon, ma'am. This is uh, this is a very prestigious day for us, a very auspicious day, Ram Navami Day. And on this particular day, we have a wonderful program coming up for TB elimination. And this is nothing bigger than that can happen to Indian Academy of Pediatrics to show our solidarity with the government of India itself. And we have most eminent personalities coming from government of India for today's program. And we, along with them, join to eliminate tuberculosis with a slogan, we want to be there with them, with their solidarity. So for this program today, I would love to invite our president, Dr. Neelam Mohan ma'am, for her address.
Thank you so much, Ganesh. Very good afternoon to everybody. And as Ganesh said, why do we celebrate days? Most of the time, it is to remind us of something which is of absolute public health importance. I do agree that in India, allergies have taken over tuberculosis. Nevertheless, when we were last 2 decades talking most of the time in most of the meetings, tuberculosis. But yet there is some change that we see. And what is that? When we were young, we were never taught about elimination. Youngsters today, they are fortunate because we are now talking about elimination of tuberculosis from the world. And having said that, it is extremely important for India to say this because, as you would all know, one of the largest statistics come from our country. And when I was going through this, yes, it is gone less than 1%, but still, if we have to reach the target of national elimination, we pediatricians play an extremely small, important part. And through the panel discussions, etc., you'll realize why the pediatricians play an important part, why children are more exposed, why children have higher mortality, and that is why we play an extremely important role in this entire gamut when we talk about national elimination. And it is indeed my pleasure as the president of Indian Academy of Pediatrics to shake hand with the government and say, we are with you. We are there to do what you tell us to do. And united we stand in this. As you can see that when we talk about this, it's a pleasure to have Shobani Ranjan. Before she gives her address, I would take a minute to introduce Shobani Ranjan. If you can see that she obviously has been in the Central Health Services for more than 2 decades, and she's taken over as Director Deputy General Tuberculosis in the Central TB Division. And she's done great work in public health. Really proud of you, ma'am, Shobani, ma'am, where you've worked not only in HIV, AIDS, then you went into blood transfusion services for the government. How important roles you've taken. And now we can see HIV is really, before it could spread like wildfire, government has really done a lot of work in HIV, and it was through the government centers that they've taken. Now, when it comes to tuberculosis, it is not only that the government sector needs to be looking into, it is our combined responsibility because pediatricians in the private sector need to understand why we cannot overdiagnose, why we cannot underdiagnose, what are the right methods of diagnosis. Gone are the days when any child with abdominal pain and a MANDU positive would be started on tuberculosis. So today in this, we are going to first understand what the government is doing. And I would request Dr. Shobini Ranjan, Madam, to talk to us about the work that is being done to strengthen the policy level and what is the strategy of the government when they talk about the National TB Elimination Program. And after that, we will hear from the ICMR team. But over to you, Shobini ma'am, and what you would expect, what the government is doing, what the experts are doing, what you would expect from us as a society, and to us how what you want to dictate to me as the president, what I need to do. That's what we want to hear from you. Thank you so much for joining us today.
So thank you, Dr. Neelam. It's indeed my pleasure to join this gathering of experts of Indian Academy of Pediatrics under your presidentship. And you have indeed set the context in terms of what the program requires from pediatricians. So I'll just briefly tell you about what the program is doing. As you're aware, we transformed from the RNTCP to the National TB Elimination Program a few years ago. But now we have taken on the role of being the TB Mukt Bharat Abhiyan. And this metamorphosis is not just in nomenclature, but it is also in terms of strategy, where we have moved towards a whole of society and a whole of government approach in making every stakeholder equally responsible for ending TB and not just the medical fraternity. So you are aware that tuberculosis continues to affect an estimated 2.9 lakh children under 15 years in India, accounting for nearly 11% of the total incident TB burden as per the Global TB Report of 2025. However, only about half of these cases, that is 1.3 lakh, are currently being notified under the National Tuberculosis Elimination Program. And as you're aware, we have a portal called Nikshay portal, where we expect that all the notifications are reported to us. So the first point I'd like to say is that we have a significant gap in detection and reporting. So where I do believe that the Indian Academy of Pediatrics has both representation from private sector and government sector. So my appeal will be for those who are probably treating this disease but are not reporting to definitely report on the Nikshay portal to us. The second thing is that pediatric TB presents unique challenges, especially in the diagnosis. So children often have non-specific symptoms, and obtaining bacteriological confirmation is difficult, leading to reliance on clinical and radiological judgment. And these challenges are further compounded in case of drug-resistant TB, extrapulmonary TB, and TB among very young children and adolescents, where clinical decision-making becomes even more complex. So you are well aware that in our health systems, while the program we have decentralized to even the Ayushman Arogya Mandir and to even the outreach facilities within the public sector, but our availability of specialized pediatricians across the cascade is limited. So I do see a role of the providers who are associated with Indian Academy of Pediatrics to support us in being able to quickly identify, diagnose these children and support the system in bringing them up for treatment, and if required, triage them under the differential TB care to a higher level of service delivery. So what I would also like to share with you is that NTEP has taken many steps to improve the access and the reach of TB diagnosis, TB treatment to the very grassroots. So one of the important things is that we have upfront rapid molecular testing, which is available through CBNAT, TrueNAT, and now some other machines called PathoDetect. We are also looking at RT-PCR. And these are available across almost all the block levels. So we need certain, I would say, there is provision of child-friendly and flavored dispersible fixed dose combinations for drug-sensitive TBs within the program. For drug-resistant TB, both shorter, 9 to 11 months, and longer, 18 to 20 months regimens are available, along with newer treatment options such as the PPOL-M regime for adolescents. And additionally, all oral regimens, including delaminid and bedaquiline, are being provided for eligible children to improve outcomes and reduce mortality. So I do see Dr. Sangeeta here, and with the support of National Institute of Tuberculosis and Respiratory Diseases, CTD collaborates to do a monthly national difficult to treat TB clinic, where there is a very dedicated focus on pediatric TB. And this platform enables the connection of our pediatricians who are perhaps working more at the urban level or at corporate level or at tertiary level to engage with our TB program functionaries and the health system functionaries to engage in cross-learning and seeking expert guidance for managing complex cases. Then I'd also like to tell you that contact management remains a major pillar for prevention. And all the child contacts of pulmonary TB patients are actively screened. Children under 6 years, irrespective of symptoms, and those who are aged 6 to 18 years through a symptom-based evaluation and chest radiography were indicated. So after excluding active TB, all eligible children are initiated on TB preventive treatment as per national guidelines, including shorter regimens like 3 HP or 6 months of isoniazid with close follow-up. So we need your support to improve the uptake for the TB preventive treatment, which we see in the program is below optimal levels. My last but not the least point is that undernutrition for us is a very critical factor closely associated with pediatric TB. It increases the susceptibility to infection as well as the disease progression, and it also is worsened by TB itself. So this creates a vicious cycle. This is not something that I am actually attempting to teach to the already learned, but it's only to highlight that the program is making attempts to address this nutrition as an important pillar for elimination by providing support of rupees 1,000 per month under the Nikshay Poshan Yojana to support nutritional needs. And this is across the treatment duration. So if the treatment is for 6 months, it is 6,000 rupees. And if it is higher, it is greater amount. Additionally, we also have a crowdfunding initiative called Nikshay Mitra, where we allow the community to participate by providing food baskets and psychosocial support to the patients who need them. So in addition to this DBT or cash transfer, there is provision for civil society, for corporates, for even individuals to associate with the program. Now we have launched something called the TB Mukt Bharat app, where the Nikshay Mitras can directly register for either cash or kind support or for psychosocial support. The third point for nutrition is that there is provision for energy-dense nutritional supplementation for patients who are below 18.5 kilogram per meter square body mass index. And I'm sure a lot of children would fit into that criteria where they need additional nutrition for the first 2 months of treatment. So I've just tried to highlight a little bit of what we are doing and what we can, seek support from all of you.
So in short, you want us to ensure the reporting, because we have to have 3 messages very clear.
Yes,
one is reporting. Second,
yes.
if there is any difficult program,
Yes.
we will say that this is the connect, whatever this day you need to connect.
Yes.
And third thing, you want to say anything else?
The third thing is the nutrition part. If you
nutrition part.
increase
So these
the
3
knowledge,
things we
these
will
3
work.
things.
And actually, I'm very happy to say and wanted to show to everybody that there is this government of India has taken a lot of associations with them. All the NGOs that are collaborating with government for the TB, like Sati, etc. We've joined hands with them, and you have the logo of TB. So we are showing that 1 in 10 cases is TB. We've circulated this to all our members, and we'll pursue with this more in this regard. Thank you so much for your coming over and motivating, because this, a part of your video with your clear messages, will circulate to all the members after the panel discussion, and clear 10 messages from them like this, which they've given. We will do that and circulate. Thank you so much, madam. Over to Ganesh.
Thank you, ma'am. Thank you so much. Madam, it was really eye-opening for us. You put up some hard facts and the way forward. And Dr. Neelam, madam, at the helm of affairs will definitely do something great in this journey. Now I have with us Dr. Singara Velu sir, who's our president-elect and a very senior pediatrician academician since last almost 40 years. So I request him to join and give his address, and also to welcome our guest of honor, Dr. Nivedita Gupta ma'am. Over to
Thank
you,
you.
Dr. Singara Velu sir.
Thank you, Ganesh ji, for your nice words. At the outset, I really congratulate our Neelam president and the team who are involved for today's program, our HSG, our finance secretary, and our VPs and EB members, and all our stalwarts in TB. I really happy that what Shobri Ranjan ma'am told, because I have been in the government for more than 30 years and I was committed in TB elimination program. As well as a dean, we brought this CBNet, which was not available. The government now is doing a lot, and definitely TB is getting under control, but still now we are in the stage of elimination. We are focusing towards, and the concept of diagnosis still there is a lot of gaps are there in the practice. So definitely today's program and the stalwarts like Sankita Sharma, our Varinder, and all others who are going to give a talk, definitely it is going to be a great and very useful to our practicing pediatrician. And Madam Sobini, Madam, we are happy that as a IMA person, as a Rotarian, we are every organization is committed to NTB, Madam. We are doing a great work with the support, and really through many organization, I really congratulate you for the tremendous work the government is doing and seeking the support of NGOs, Madam. Thank you. And now coming to next job of having another great person as a guest of honor, Madam, who is Nivedita, a great scientist. More than 20 years she worked in vaccinology and viral diseases, and her work during COVID is laudable. Madam, because of you, I can say, in India, we were able to get lot of labs, because there in the beginning, how much we suffered to make a diagnosis because lab shortage was there. You were at the helm of the hour at that time. You gave permission, and a lot of machines came, and everywhere the investigation became very easy, Madam. Hats off to your work. And apart from that, you are a great academician. You have published so more than 100 papers and 5 books you have written. And your work now, you are in ICMR as a research person and committed to virology and other infectious disease and vaccine development, Madam. Definitely, we are really honored that to have you as a guest of honor. So with your words, definitely our organization will be still more committed for elimination of TB. Thank you, Madam. Over to Ganesh to welcome Madam.
Thank you, sir. Thank you so much. So today we have an eminent guest of honor, Dr. Nivedita Gupta, madam, who's actually the commissioner or the divisional commissioner in the ICMR, and she has agreed to be here on our platform and enlighten us with her address. So I request madam to please say a few words.
So first of all, thank you very much. And at the outset, I would like to thank Dr. Neelam Mohan and Professor Singara Velu sir for your very kind words, as well as Dr. Ganesh. So as rightly said, that I have been working in the area of viral infections and vaccines for more than 2 decades. But now I'm heading the Division of Infectious Diseases at the Indian Council of Medical Research. And while heading this division, TB is an inevitable part and one of the highest priorities that we are working on currently at ICMR. So first of all, ICMR, the highest leadership of ICMR, that is our Director General, who's also the Secretary of Department of Health Research, along with all the senior leadership, is very committed to support the Central TB Division in bringing all the research innovations as well as all the demonstration models that could help the program in fast tracking TB elimination. So we are there to back them and support them in their goal of TB elimination in a timely way. And as most of you would be aware that in the past decade, I would say that ICMR has attempted to bring certain innovations as well as certain very valuable information to the program in terms of validation of the TrueNat TB test and now the PathoDetect test. The handheld X-rays were also, first of all, validated by ICMR and recommended to the program, and they have become a very easy tool now for to enable the program to go to the community and screen more and more people for TB. And as we all know that there was a limitation, there still is a limitation of radiologists in the periphery. So ICMR collaborated with the Plasma Research Institute and brought in a AI tool for X-ray reading, which actually classifies the X-ray images into normal and abnormal. So you click a picture from the handheld X-ray machine and you use the AI tool to classify these images as normal, abnormal. We are further working not only with one agency but with several of them to refine the tool and also be able to classify as TB and no TB so that it further facilitates the program. A TB prevalence survey was done by our institute, National Institute for Research in TB, which was the largest ever survey done in India. And it also brought out the national as well as state level estimates. The ration study actually, which was conducted, helped, I would say, supported by ICMR, brought in very valuable information on the role of nutrition in preventing TB in household contacts of TB patients. And very recently, we have also come up with innovations like open PCR for TB testing, which is extremely cheap. It can be brought down to 100 rupees. And also a palm top device for screening samples, non-sputum samples for TB. So we have validated a tongue swab based test for TB, but we have validated it in adults. And as per the request of the program, now we are going to further do bridging studies in pediatric population for assessing the use of this non-sputum based testing modality in pediatric population also. So do we understand that TB detection in pediatric population is a huge challenge, especially getting sputum really becomes challenging, and gastric aspirate sometimes becomes the mainstay of diagnosis, which actually is very challenging and requires a healthcare facility. So ICMR is very committed to explore and also validate as well as help in development of tests which are non-sputum based. We are looking at blood-based tests as well as stool-based tests, as well as saliva and tongue swab-based tests for TB detection. Though they would have a low sensitivity, but perhaps we can use them as screening tests and club them with some other second confirmatory test to help the program as well as help the pediatricians in detecting TB in pediatric population. So all I would say that we are very committed towards this objective and this goal of TB elimination. We do understand the challenges of detecting TB as well as treating TB in pediatric population, and it's one of our highest priorities for research. The other very important information that I would like to give this group is that very recently the Secretary DHR and DG ICMR has taken an initiative to put in place a TB research accelerator program with dedicated funding and very dedicated and focused team at ICMR headquarters as well as NIRT Chennai to dedicatedly work on research related to TB along with all the stakeholders and partners in India. Under this initiative, we have already conducted 7 different state level workshops wherein we went to states. We sat with clinicians, program managers, and all stakeholders to understand that what are the key challenges that they would like us to address through research. So the main goal that we went there was to understand what are the state level priorities. So we have gathered this information, which actually includes a lot of information or research questions on pediatric TB also. We are collating it and we will further be convening a national priority setting workshop in April, wherein we will also call all the national stakeholders and discuss with them. And I'm sure that many people in this group will be a part of that workshop. Now, what I would request the Indian Academy of Pediatricians is that we would also be very happy that if you could also put in your research questions and give them to us. What would IAP want ICMR to do in terms of research? And when I say research, sometimes research gets mixed up with service provision. So if you could segregate and tell us the exact hardcore research questions that you have for ICMR and give us one document on that, as we have done with the states, we would be very happy to look at those research questions. I would not say that we'll be able to address all of them, but definitely the most burning ones we can take up as research priorities, research projects, involving many of you also. So that would be extremely helpful if you could give that to us, as well as we will publish expression of interests related to the TB Research Accelerator program in April end or May. And I would urge all of you to kindly participate in those research studies, because you will be the one who will be really able to conduct them. You have access to the patients, you understand the disease well. So I invite all of you to participate in the expression of interest that we would be publishing on TB research. We would be publishing certain key questions and inviting the proposals on that. So we would be very happy if you all participate in that. So with that, I would again just emphasize that we are very committed at ICMR. We do understand the high priority that the TB disease holds, and we are very committed to support the program and the researchers in India, as well as the clinicians in India, to help eliminate TB. So with this, I'll stop, and I wish all success to this very great event. Thank you so much.
Thank you so much. That was very useful, Nivedita, with very crisp questions. We will form the ID team to give us all the questions. And fortunately, we have two of them already in the panel, which is going to come. And we will share that questions with you. And subsequently, if there is any research that you are doing, we will form a team from our side called which will work for the next 2 years. I speak on my behalf and on behalf of Dr. Singaruvelu. We talk to each other before coming over that whatever program we take, it will not be left for this year. We will do it this year and next year. The committee will work towards it with you all. And we'll come out with, as the time needs be, the position papers, what needs to be done. And I've heard a lot about Matuji. And we are very fortunate. Matuji is well with us, and I'm sure he's in the same team as Shobini runs in GMR, right? Matuji, you're in the same team, and you are a very, very popular person with all the pediatricians. So we will not hesitate to meet you within a couple of weeks. That's a commitment. Myself, or if I'm not there, I'll try to be there. And we will come with a joint secretary liaison team. And when Singrabal is here, we'll see when his availability, all of us, because we want to talk and understand. And IIP is committed and focused, gone bypass whatever issues are there. We are here to work together with a clear goal of national TB elimination, and the main the bottleneck is the children. So for the bottleneck of the children, how we can help you all, where it is going, as I'm told that reporting is going less, and I'm told how important it is to do the gene, which is expert test and all, which are so cheap now and freely available. So how we can assist in disseminating, we will do it from the IIP, and both myself and Dr. Singaruvelu will chair this project for you all. So with those words, I thank Nivedita, and over to Ganesh. Let's introduce the panel and let's
I also acknowledge our President Neelam's view. Definitely, we work together to help and eliminate TB, and also bring a lot of research aspects. A lot of scopes are there in TB research. We will do that, madam. Surely we will meet both of you soon, madam. Over to you.
NS commitment. Thank you.
Thank you so much. Thank you, Nivedita, madam. As assured by our president, I suppose no program can scale up to its height without the support of government. And together with government and IIP, one can really do great for our society, for our kids. Over to now, Dr. Vasant Khalatkar, sir. He is our immediate past president. I invite him to have his word of address. Dr. Vasant Khalatkar, sir.
Not seen.
I think he's got a technical
It
hitch in his.
wasn't there. He had sent a
So
message.
I invite now going further, we're going to have a wonderful academic discussion. And then the slogan itself is TB elimination. Yes, we can do it. On that basis, so we are going to learn about pediatric tuberculosis management, the challenges and the way forward. And to deliver that, we have a wonderful moderator who herself is an authority in the tuberculosis programs, elimination programs. And I invite uh, Dr. Sangeeta Sharma, who's going to enlighten us for this particular panel, along with senior panelists, Dr. Sanjay Mathu sir, Dr. Varinder sir, Dr. Manjula ma'am, and Dr. UB Singh ma'am. So I request Dr. Sangeeta Sharma ma'am to please
It's
initiate
a
her panel.
wonderful, if you have seen, I think we've handpicked Dr. Varinder is the person who has done his name in tuberculosis from MC, highest amount of papers and all. And Dr. Mattu is totally dedicated to tuberculosis. And we have the AIMS microbiologist. So it's a beautiful this thing where they will give us, and these key messages will be drafted. And don't think that there are few members in the group, but they will be drafted and circulated to all the branches of IAP. This program and messages will be circulated. Thank you.
And moderator Sangeeta's commitment is laudable, madam. She is doing a great work. Madam, we IAP will be with you for all your endeavors, madam. Over to you.
So, thank you, Dr. Neelam Mohan, our president, and Dr. Sangralu. You've always been a source of encouragement to me, and I totally thank the initiatives taken by our president that we are in this fight together with NTP towards ending tuberculosis, that is TB elimination is our goal. So I'll now begin my presentation. You can see it.
Yes, ma'am.
Is the PowerPoint visible?
Ma'am, your screen is visible. PowerPoint. Huh? Yeah, yeah. You can go back,
Yes.
ma'am. Yeah, go
Yes.
to the first slide,
Yes.
ma'am.
Yes, please. So I've been given the very important task of moderating this very important panel on the occasion of World TB Day, highlighting the commitment of Indian Academy of Pediatrics towards TB elimination. And I'm very lucky that I have all the stalwarts with me in this panel. My senior colleague, Dr. Varinder Singh, who is was director professor at Lady Hardinge Medical College. Then Dr. Urvashi B. Singh, who was our DDG TB, and still she is the head of TB diagnosis division at AIMS Delhi, and Dr. Sanjay Mattu sir, who is the joint commissioner at Central TB division. So with this strong panel, I'm very hopeful that we'll be able to do justice to the topic which has been allotted to us. So we'll be discussing about TB management. It will be case-based, and we'll be also going through the challenges and the way forward. So as I've said, we'll be also discussing the challenges and the newer initiatives which we the government has undertaken. So, moving to the first case, that is case 1. This is a 7-year-old male child weighing 18 kg who presents with the following symptoms, that is fever, cough, anorexia, weight loss. There is a significant weight loss. Weight loss has been defined as more than 5% in past 3 months. So this is more than that in last 3 weeks. And this was the chest X-ray, which shows right upper lobe cavity. And the sputum examination is AFP 3+. So my question to Dr. Varinder Singh is, do we need to ask any further questions before we start ATT in this child? Because the diagnosis is at hand. The child is smear sputum positive 3+, and the chest X-ray is showing cavity. Would you like to ask some question, or you'll go directly to the treatment part?
I see two action points here. You see, in current era, just knowing TB is not enough. It is important to know whether this TB is likely to be drug sensitive, for which there are two ways we can do it. One is the epidemiological features. So asking about history of treatment in the child, whether this child had been treated in the past or had not completed or has failed on therapy, is something which will give me a clue that possibly while this is AFB3+, but this may not necessarily be drug sensitive. Or this child, which is more often the case in pediatrics, this isn't cavitary TB here, but in a lot of children, they have closed lesions, but yet they have drug resistance TB. That's because they get transmitted drug resistant TB, and therefore a contact or exposure to someone known to have drug resistance TB, somebody who has died of TB, because death due to TB is more often seen with drug resistance than with drug sensitive, could be used as a kind of a pointer or a marker to suggest that things may not be as simple in this given child. So in current era, that's one thing to look at the epidemiological features. The other is that we should not stay with smear alone. We should not be happy with that. We have now rapid molecular tests available to know uh, whether this particular child is harboring as drug sensitive, or at least for rifampicin, it will be able, our first line test would be able to tell us whether there's rifampicin resistance or not. So therefore, my first question, if I have to ask just questions and not actions, would be more around the history of treatment within the child or exposure to someone who's likely to have drug resistant TB.
So these are very two important questions with the history which need to be asked. A past history of ATT or history of contact. So what it emerges is that the grandfather had died of tuberculosis 6 months back. Although there are no papers available, but on questioning, the grandfather was on some injectables as well. So, now what would be the appropriate tests which you would like to address to? And would this definition change from presumptive TB to presumptive DER TB? Dr. Vrinder, if you can highlight what is presumptive DER TB?
Yeah. So a couple of things to stick with your case and then elaborate there further. Now, this child has smear positive and has some contact with someone who was on injectables, and as we know, injectable is not first line therapy, so likely to have exposure to drug resistance TB. There are few things which current technology allows us, and we have used it in many of our patients. One is whether if the patients will often, particularly when there is a death or there is a cure, they will lose the papers because they think there is no more sense or there is no advantage of keep retaining those papers, health records. So e-register, e-TB registers help us a lot. So we have in the past used the telephone number or Aadhaar number if the family is willing to share that, or assisted them with that to find the information on the e-register about the source case. So it's not a dead end if the parents do not have the papers. With the current level of documentation within the program, this is one way you can access more information. So that's one thing which helps. You would have also think in terms of that a lot of pediatric TB, despite all the methods which are available, still remains a clinico-radiological diagnosis, because even the best situations, you will not get a positive molecular diagnosis in about 40%, 50% of situations. This index case is different. This index case is smear positive. So here, the possibility of a molecular diagnosis being negative is not there because the sensitivities of the molecular test is much higher than the smear. Maybe LP is similar, but if you go to any of the TrueNat or Gene Expert, their sensitivity is in 100, while smear positive means more than 10,000. This 3 plus, which is much higher bacillary load. So you would get a molecular diagnosis. However, in pediatrics, when you do not have, you have a similar case but not a similar X-ray or sputum which is negative, then you have to consider a presumptive DRTB. The presumptive case is someone who's likely to have drug resistance because of the history, and here the history is of a possible exposure to an MDR case. So therefore, yes, this is a situation where you will call it a presumptive DRTB case. So does it mean that we only change the nomenclature? No, we just don't change the nomenclature. The nomenclature, we could say like Shakespeare, what's there in the name, but there's a lot in the name. Because once you label something, then you have to prove it. So if I say presumptive DRTB, then I'm not going to be satisfied with, okay, sputum not available or GM. Then you have to go all out to find the bug and make sure that you are able to get a culture or a yield to get a resistance pattern. However, in few situations where you are not able to get it, there may be a case for a probable DRTP case, but drug resistance is largely a microbiological diagnosis. It's not a clinical diagnosis. You cannot never see an AFB with naked eye, nor can you see the behavior of the AFB or Mycobacterium tuberculosis in naked eye. What is also important to mention here is that your body, our body, responds the same way to MTB irrespective of its drug resistance. So you can have a primary disease with a bug which is resistant to almost every drug. So it is not essential that they would have extensive disease. Eventually, because the disease will progress, it will become, multifocal, but otherwise not. It
So
could
it's
be.
very important, the points which Dr. Verinder has highlighted. So even if the death in the family is there, there are no records available. There is what we call as the Nikshay ID. So that ID is like a sort of a Aadhaar card, which remains the same throughout the lifespan of that particular patient. It's linked to the social demographic data, so that can be retrieved. One thing that is very important. And the other thing which Dr. Verinder has highlighted is that we need to take a detailed history, do a detailed journal physical examination of easily accessible sites. What we tend to miss is like we have a case of like abdominal TB or genitourinary, and we are trying to find out the organism, trying to get the samples, but we are missing on the cervical lymph nodes, or a forgotten sinus somewhere, some part of the body. So please, it is very important to get to change our mindset that microbiological confirmation is not possible. With the newer diagnostics which are available under the program, we at least need to try. We need to send appropriate samples with proper SOPs to an accredited lab. So with this now, I would like to ask Dr. Urvashi, what are the newer diagnostics which are available under the NTP, and what are the measures which can increase the sensitivity using these tests? And what are the diagnostics which are likely to be introduced in the near future under NTEP? So, Dr. Urvashi.
Good afternoon, all, and thank you to the IIT, Dr. Neelam, and President-elect Sir, Dr. Sangeeta, Dr. Varinder, and Dr. Shobini, Dr. Vedita, Dr. Matu, all my very dear colleagues of several years. This is, all these questions are wonderful questions. And as far as children are concerned, I always feel there are differences in the basic biology of disease, how it presents in children because of the weaker immune response as compared to the adults. So we do need to take extra care, like, we take care of children more than an adult. We do need to take an extra care, starting from sample collection to the results and what all tests can be put to use. So let me start by saying that the point of care tests that are today being talked about, and I would like to reiterate that we, of course, Gene Expert was the first point of care NAT test, but did not go beyond the district, could not go beyond the district because of want of electricity supply, storage conditions for cartridges, and so on and so forth. What we have is the Indian indigenous TrueNAT system, which was painstakingly developed, within the country with support from all experts from all over the country. We validated it in a multicentric study under ICMR support, and then the program adopted it in 2018. Now, both these tests offer similar sensitivity, and we have published a multicentric study, again, proving that both are equally good. So TrueNAT can in fact reach the periphery, is battery operated, is available in UNO and Duo platforms as well. Hence, we can actually think of taking them to CHCs, and several CHCs today have the TrueNAT platform. Under the program, we have more than 10,000 NAT systems today. Close to 2,000 of these are CBNATs, while close to 8,000 are TrueNAT systems. So such has been the scale up of our NAT systems under the program. And frankly, the nature of this being Indian indigenous ensures that the supplies are not affected. Recently, ICMR has validated the PathoDetect system as well, with the advantage that it can give us INH resistance detection also, in addition to rifampicin detection. How that helps us is, of course, a matter of, deciding the regimen. So when we, the times when rifampicin resistance, we got the point of care for rif resistance, we were all elated and more than happy that we can start the regimen tailored to the patient's needs. But with the INH resistance increasing, and the NDRS in 2016 actually showed us substantial INH resistance, whether it was primary or acquired was definitely much more. So the point I'm trying to make is we need to know resistance to more than rifampicin. So PathoDetect is offering that, and soon there are several other tests which are currently under validation by ICMR, will be able to provide us. We'll have more, point of care NATs, which will give us INH in addition to rifampicin, and also what we have been pushing as, as the former DDG, and, I've been a macrobiologist at AIIMS for 33 years now. We have been telling companies like MolBio, MyLab to bring up a fluoroquinolone NAT as well. So they're all working on it, and currently ICMR is validating the TrueAMP test, which offers both INH and fluoroquinolone in addition to rifampicin, and soon that study will tell us how it is performing. In addition, PathoDetect has also come up with fluoroquinolone. In fact, we were telling them to bring up bedaquiline as well, because that will further help us whether we can, if at all, initiate a bedaquiline-based regimen in our MDR children. So much so for the NAT systems and what is the strength. What Dr. Sangeeta brought in was a very salient point, and I partly alluded to it in the beginning, that children present the disease differently. So it is very well known that in children, either they can land up with primary tuberculosis immediately after infection, or the immune system may be able to take care of the disease. And sometimes the children may not have an active parenchymal lesion, while they may have mediastinal TB. Hence, the term we use for, we use intrathoracic TB to include the parenchymal TB as well as the mediastinal TB. And often there has been a question, Gene Expert or TrueNAT doesn't give as high a sensitivity in children as in adults. The reason being a substantial proportion of children present with mediastinal TB, because the immune system is trying to fight, contain the disease. In children who do not have a parenchymal lesion or a cavity communicating with the airways, the sputum or induced sputum will not be able to give us the yield. This is, we published to this effect in Frontiers Pediatrics about 3 years ago. So what I'm trying to arrive at is the TrueNAT or Gene Expert, where only the sputum is being subjected to the test, may not always give the answer. So that further explains what was being discussed, that we may not always get a good yield. Culture in our labs, we have even reached 45%, but on an average gives us about 10 to 15, max 20% in most labs. 45% we were able to achieve when it was part of a PhD thesis, when the sample was inoculated the same day. So this misconception that it is a sturdy pathogen, if you store, nothing would happen if you inoculate the next day. Let me correct that. The earlier we inoculate the culture, the transport of sample, the better it is taken care of. The earlier the transport of the sample is there, that is, it reaches the lab, say within 4 hours, would be optimal and immediately put onto culture. This has given us better yields, in fact. Now, what I'm actually trying to arrive at is, in our lab, we published a series of papers with Dr. Kabra sir, Dr. Lodha, where we have been able to show that often a single sample may not give us the yield. So what we would do is we would take 2 induced sputums and 2 gastric aspirates. And if the clinical suspicion would still persist, we would in fact go on to do a BAL in such a child, which I understand is not something easy in the periphery. Nevertheless, what I wanted to reiterate was more than one samples may do the job, where a single sample. So when I said 2 on 2 different days and gastric aspirate also on 2 different days. Now, in addition, of course, Dr. Sangeeta did talk about samples other than the pulmonary samples. Again, we have done work. So if I may take you back to 2013, when WHO recommended urinary LAM test, which is a antigen, it's a TB antigen, actually excreted into the urine. This in 2013 was recommended by WHO for people living with HIV, because early diagnosis of TB could save these PL-HIV. By, you could actually initiate treatment. The specificity of this urinary LAM is very good. It is more than 95%. Some say 95 to 96%. Sensitivity is not so great. It reaches about 60 to 70%. And what we did in 2013 was I just, felt that the children may also be, immune compromised, may not be as immune competent as our adult patients. So we planned a study and we published this in 2019, IGTLD, and we were able to show that the urine LAM, since the specificity was so high, was able to perform better than GeneXpert. It picked up patients who had been clinically initiated on treatment and had responded. So the message I'm trying to give is additional sample. Urine LAM is one such sample. Moving on to the use of stool, there has been a lot of publications, and we worked in a collaborative project, but unfortunately COVID happened. This was a funded project where 2 sites in India, several sites in Africa, and this we published recently in CID last year. And we found one particular extraction method was useful, and we were able to utilize the stool sample using NAT as the diagnostic sample. It gave us a good yield. Let me also take you to another story, what we have done. Now, years ago, when I initially started, I'm talking 90s, what we would do is, in case, some patient would have clinical, subtle clinical symptoms, the clinician would doubt TB, we would pick up with an in-house PCR DNA in patient's urine. And often it was found that this patient who was responding to a clinical decision of initiating ATT was having this PCR positive in the urine. However, there were a lot of questions raised, oh, in-house PCR, oh, open PCR, there may be contamination, this and that. We dropped it, but in case the patients would request, we would still oblige. What we did in the past 3 years, three years back, was we picked up urine and did GeneXpert Ultra. So not only from pulmonary TB in children, but also from extrapulmonary TB in children. And lo and behold, we found it was a wonderful test. So basically what I'm trying to do, the concept behind this is we were trying to look for cell-free DNA present in the urine because it got filtered from the kidneys and it was available in the urine. In fact, what we could do was we picked up retrospective samples, and because we wanted to look at how GeneXpert Ultra would perform in these samples. So the final message is children may not present as typically as an adult would present with TB. Hence, we need to actually broaden our perspective that instead of questioning why are they behaving like this, of course, their immune system works differently. It's an immune system that is learning to cope. It is a cell-mediated immune response, and the CMI builds as the child grows, of course, on exposure to infections. Now, so if the child is presenting in such a way that the pulmonary sample is not the sample which is performing well, for adults, if I may say, a pulmonary TB will grow culture in 80% plus patients, often to 90%. And of course, the NAT results are also great, very highly sensitive. In children, we could consider taking more than one sample. Why only pulmonary? We can also take urine, we can take stool. Of course, we have the likes of interferon gamma release assays, which do not perform well. And I'm not a proponent of those IGRAs, whether it is IGRA, whether it is MON2s, whether it is SciTB, for going in favor of diagnosis of disease. They could be used for diagnosis of infection. But to my
Dr.
mind,
Urvashi,
even for infection, I'll wind up, Dr.
yeah,
Sangeeta. Yeah, she asked the question, how can you improve the sensitivity? My answer is, have more than one sample.
Okay.
Take more samples. There were studies published where PBMCs were taken from children with, presumptive TB children. These PBMCs were first treated, and the DNA in the PBMCs were, NAT was, the PBMC extract was subjected to a NAT to diagnose TB. So as technology improves, we'll have more techniques available to us. And Dr. Sangeeta, was that all? Did I
Yeah,
answer all three
there is a
questions?
quick question which I want to ask you. There is a lot of confusion in the mind of pediatricians. Do we need to neutralize gastric aspirate, yes or no?
No. If the message can
And
go.
also, IGRA, what she said, that was also because you see a lot of prescriptions coming with that.
I'm sorry, I didn't get that.
IGRA
Yeah, there are a
testing, which
lot
you
of
said was.
prescriptions coming for
So
IGRA,
you see, we have IGRA. I'll talk again. So the again, this is a misconception that if exposed to acid, the organism will not grow or the DNA will get harmed. So in the lab, we take good care that when it comes for a culture, we do decontamination, we do multiple washes before we put the culture. Even before we put a NAT, we take good care of the sample. So we need not worry about the stomach acid that
No,
was
but this
the
is in
so-called.
your lab, Dr. Urvashi. What about in the periphery?
So,
And
Dr. Sangeeta,
neutralization,
yeah.
because
So if
WHO says that, the sample needs to be neutralized, but then there is always a risk of contamination.
yes,
So,
and
I mean,
also
there are
the risk
conflicting
of
studies.
yes, also the risk of these salts that you may be using bicarb or something to neutralize. All these salts can cause inhibition of the PCR, so we do not recommend them.
Okay.
We just do not recommend them because
That's a very
and
important
let me
message.
also reiterate, the lab protocols with time are getting very strong, and there is training of these technicians or whosoever is dealing with the samples. We have frequent trainings. There are internal quality controls, external quality assurance programs. So all this goes on behind the scenes. And kudos to our lab experts who never demand any limelight. I was noticing that there have been some anyway, what I'm trying to say is there is a lot of work that goes behind the scenes, and we take care that the lab protocols deal with like I said, our culture yield has gone up to 45% when we ensured no delays. So no delay in sample transport is something very crucial, whether it is for a NAT or for a culture. So, and we have taken care under the program. I will allude to when probably if there's an option to. So the program has gone on to train its labs to in fact do, I started the training for DST for bedaquiline and predominant at the baseline. Phenotypic DST, 43 labs are certified today. In addition, we started targeted NGS so that at the baseline, at least we know drug resistance to all the second line drugs in an MDR TB patient. So what we planned to do was offer targeted NGS to all MDR TB patients. But what I could roll out during my time was 5 centers of excellence of MDR TB had started doing targeted NGS, and we will soon scale it up, to other labs.
So very, very important messages, Dr. Urvashi.
One more, if I may,
Combining
Dr.
this.
Sangeeta, we also trained our labs to do FDA staining, which will discern live and dead bacilli. And again, we need to just push the labs to offer it to everyone who needs it. On treatment, we can actually know if the patient is responding or not responding, because NAT is not a good prognostic marker. And culture may not grow because the bacteria will become viable but not cultivable on ATT. So this is one
a
good
very
technique we
important,
can
yeah,
do. Yeah.
very important test which you are saying, that because you know culture, whether the patient is improving or not, especially for MDR, you need to have serial cultures, you know, and culture may not grow the organism always. So this test is a very important handy tool, and combining specimens is one thing which Dr. Urvashi has highlighted. And
I meant more than one specimen.
yeah, yeah, from
Specimen
more than
may
one
be one
site,
answer we want to
like,
economize, but as of
yeah,
now, I'm not really recommending that. That's
yeah,
only if there is a shortage. I'm saying more than one specimens could be
yeah,
looked at with the right.
pulmonary and stool, or with non-respiratory specimens. To in urine, blood is also emerging as a important markers. There are still studies going on. So we have had a very fruitful and a very good discussion, and you've given us a true insight into what is emerging as regards to the newer diagnostics. So moving ahead now, I would now request Dr. Virender to, guide us through the stepwise diagnostic algorithm in a new presumptive TB case, like the case which we had. How would you have gone ahead in diagnosing this child? Which algorithm you would recommend to be followed in a new TB patient? Dr. Virender?
Oh, yeah, I'm there.
Yeah.
So, the first thing is that uh, we have to make a comprehensive algorithm, as Dr. Urvashi also mentioned, that children are different, they're not miniature adults. So you start with certain features which make them more likely to have TB, like persistent fever more than 2 weeks, unremitting cough, not recurrent cough, weight loss, and blah, blah. So based on that, your first screening tool is not in the case of pediatrics, a sputum sample, because that's often not available. So it's not a respiratory specimen, it's a chest X-ray. And this also helps us optimize the cost of, diagnosis. One could argue that you could sometimes have chest X-ray normal and hidden areas, but they're occasional. Most patients, your starting point is chest X-ray. And based on the chest X-ray findings, you take your next steps. So if chest X-ray is highly suggestive, what do we mean by highly suggestive? The highly suggestive, which is more likely to be tubercular, like lymphadenopathy, mediastinal or hilar, or chronic fibrocavitary disease, or a miliary pattern. These are considered as highly suggestive. They're not diagnostic, but highly suggestive. They can also have other differentials. And then there is non-specific, like radiology, like collapse, consolidation, infiltration, uh, so consolidations, sometimes you could have a persistent pneumonia, which is non-tubercular also. So in those situations, it is very important that we first give them a course of antibiotic if an appropriate course of antibiotic has not been given. Often in practice, no, I'm not saying government or private, in practice, choice of antibiotic is not correct. Sometimes in a country where uh, deficiency of third generation cephalosporin leads to fever, there is an or of fluoroquinolone, there's a misuse of that. So that's not an appropriate antibiotic, and your consolidation may not respond because the antibiotic used, it is partially covering the bug or not covering the bug at all. So inappropriate antibiotic uses of amoxicillin, or where required co-amoxiclav, amoxicillin is the primary drug. You use for 7 to 10 days, and if the child does not improve, then you start looking for whether this is a child who's non-responsive, and then you send all possible samples. So it could be GA, it could be induced sputum, it could be a nasal pharyngeal aspirate. Now we also have oral swabs, it may be stool. The most important, I think, is to begin with is there is self-expectoration, it is the sputum, and you do a rapid diagnostic test on that, which will tell you MTB positive or not. Under the program, what you have available is an expert which has a limit of detection of 120 or 25 or 135 different numbers. Usually, culture requires about 100 bacilli per ml. So it's little less than culture to say, and it is still much better than smear, which is 10,000 bacilli. Then you have an alternative form, which is Expert Ultra, as now even TrueNAT is bringing a modification, TrueNAT Plus, MTB Plus, but then they are yet to be validated and be brought under the program, where the limit of detection is about 25. They can go as low as 15. So these are otherwise available because IIP deals both with the program and patients who are outside of the program or in the private sector, though they are notified, but they continue treatment. They don't seek diagnostic services under the program, and therefore there are other WHO validated tests which are available. So Ultra could be one of them. It has its own limitation, which we'll talk later. Based on whatever NAT you use, but these are only these three. Do not use any home-based or unapproved or when locally produced PCR or probe is talked of by a research lab like Dr. Urvashi is very different from what is run-of-the-mill labs anywhere in the country. So I am saying for a clinical purpose, only go for approved test, and approved test was just listed by Madam in the previous slide. And you look at whether it is RIF resistance detected or not detected. Sometimes you also get RIF resistant indeterminate. RIF resistant indeterminate means machine is not able to tell you. Kindly do not understand this as intermediate sensitivity as you understand that for pyogenic bacteria. It just simply says the machine did not get enough DNA to give you the answer whether there is RIF resistance or not. So you need to repeat the sample. If the repeat samples are discordant, negative, you can either do the third. If the access to sample is not possible, if there are no risk factors, you can do retest drug sensitive TB. So that's how we will go through NATs. You would also have a situation where NAT comes negative. A negative NAT does not mean the child does not have tuberculosis, right? So you can have tuberculosis. It simply means this test is not able to confirm whether you have TB or not. So your options still are open. It could be TB, it could be non-TB. Nearly 40-50% of them could be TB if your starting point is correct. And therefore, your first effort should be try a better quality specimen. When it comes to collecting GAs or other things, we often pass it down to the least trained person. The quality of specimen matters a lot. If it is just becoid secretions or just water which you have sent to the lab, it will definitely come negative. You have to have sputum in there to get it. So better quality specimen, alternate specimen, Dr. Sangeeta referred to, there could be sinus, there could be lymph node. So don't restrict yourself to one and then do that. If repeat is also negative, then you review either from a higher center. Higher center is not at a height of several feet above the mean sea level. A higher center is one which has facilities better than yours. So each one of us will have a different hierarchy of higher center. So you send to a center which is more trained, skilled, or equipped than you. And then if there is no other like alternative diagnosis available, possible, you may treat as a clinically diagnosed TB case. But you would always be on your edge because you have not proven the diagnosis. Some of them may turn out to be non-tubercular later on. It depends on how good is your clinical acumen on that. Sometimes the X-rays will come normal and child may have an extrapulmonary TB which is not visible, or may have a TB which is hidden in the hidden part of the X-ray, mediastinum behind the heart, where further evaluation, specialized investigations like CT may be needed. Maybe you have to look for alternative places because often these are patients who have PUO. So there is a whole paradigm of investigations for PUO, and TB is one of the several things which causes PUO. So that's how we use this algorithm in an integrated way to get a diagnosis. But today's time, when we talk of integration, it actually goes beyond it, which is on whether drug sensitive or drug resistant. I'm sure Sangeeta is going to allude to that little later. Thank you.
So, very, very important. Dr. Virender has taken us through this algorithm. This is for a new patient who has no risk factors. And the important thing is that we need to attempt. We all understand that pediatric TB is possibly, but attempt should always be made to, get hold of adequate specimen and send it to an accredited lab. Because what is our goal? Our goal is universal DST. By universal DST, we mean that, at least we need to try for DST for rifampicin for all patients who are diagnosed with tuberculosis. And if it is rifampicin resistance, then at least two fluoroquinolones. Because as we'll proceed further, you'll understand why all this is required, And in the future, universal DST would mean that right at the outset, we should try to know the drug sensitivity pattern to all the anti-tubercular drugs, that is to all drugs. And the other thing important is that whenever you diagnose a case as tuberculosis, be it microbiologically confirmed or clinically diagnosed, always offer HIV testing after counseling. So, because that is very important. We need to, go ahead with HIV testing. So with this, now we move further, with the results. So what it emerges is that this child is sputum 3 plus, and it turns out that TrueNut is RIF sensitive, and first line LPA, because it was smear positive. So the first line LPA, as we discussed, LPA can be done on smear positive specimens, because LPA requires minimum bacillary count of 10,000, which is there when it is smear positive. For culture, there are millions of bacteria. So, but LPA requires minimum smear positivity. So in this case, because it was smear positive, 3 plus LPA was done, and it turned out to be the first line LPA tells us about rifampicin and INH. Second line LPA tells us about FQ. So second line LPA is done only if the first line LPA tells about rifampicin resistance. And later on, even in these cases who turn out to be RIF sensitive, because we need to know about INH resistance. If INH resistance emerges, then we further need to send the second line LPA for FQ. So this is how the algorithm proceeds. So now, Dr. Verinder, I'll like to ask you, with this scenario, this is RH sensitive patient. So which regimen, what drugs, and in which doses?
So, when you have a RIF and H sensitive, then our standard regimen still is 2 months of HRZE and 4 months of HRE in our country. So that's what we're going to use. The continuation phase is ethambutol addition in addition to HNR, which is different from other countries, and that's because of higher INH resistance that we do not want rifampicin to be alone there in continuation phase, and we add ethambutol. One could argue here, when you know that the patient has INH sensitive drug, whether E should be continued. These are not often the cases that you have both the tests available to you. So as a thumb rule, we continue both ethambutol in both the phases, IP and CP. So that would be the treatment this child would require, because this child has a pulmonary TB. If this child had extra pulmonary TB, which is of severe kind, like a bone or a CNS TB, then they would require 12 months of therapy. And current therapy is one, we know there are higher doses, and it has a different fixed dose combination. The fixed dose combination, the advantage is that no drug can be missed by chance by the parent or out of whatever reason, because they're all together in one tablet. Ethambutol comes separate because it's not dispersible. The tablets which are used under the program for pediatrics are dispersible. So often one of the argument which is made is like, say, if you look at the weight band, 16 to 24, there are 4 pediatric tablets to be given. All these 4 tablets can be dissolved in 5 ml of water. So there is no pill burden. Yes, ethambutol is little difficult because it's not water dispersible. Dispersible tablet is not there, but the stability is not there in that form. But these can be crushed and used as a suspension even for 4 small tablets which are there. So it is possible to use these drugs. The program has made a small, something, the FDC, which can cover all weight bands. So therefore, you can't have countrywide, different drugs created for different weight bands. So you have one pediatric formulation, you have an adult formulation. Adult formulation is 75, 150, 400. It is a 4-drug combination for intensive phase. For continuation phase, obviously paracetamol will be out. It will be 3 drugs. And for pediatrics, it's 3-drug HRZ plus a separate ethambutol in intensive phase. And later, when you go to continuation phase, it is a 2-drug combination HNR. Why are we talking of adult formulation here also is because the moment a child crosses 25 kg weight band, then you will start adding an adult weight, tablet also to get the right milligram per kg. Now, many of the drugs which are available as FDC in the market, and they have been there for years, do not have the right combination. Remember, WHO has upwardly changed the milligram per kg dose of rifampicin and INH to 15 and 10, with the weight band of 10 to 20 for rifampicin and 7 to 15 for the bandwidth for isoniazid. So all the older for FDCs which are available in the market created by any company are not necessarily the right combination. So get out of that, the poorer combinations which may be still be there because some state is allowing the country to the company to manufacture it. And remember, these are the combinations which need to be given. So just all of the what we are talking today has been converted into a very beautiful one sheet called standard treatment workflow, and it is also available as an app through ICMR. So ICMR created standard treatment workflow, and wherein all these are available. So you can just keep it on your uh, table as a ready reckoner. You don't have to think कि वो पता नहीं वो कागज कहाँ है पी देना था कि देना था. There is no problem. Ready reckoner is good. We don't have to remember everything. It is not something that you are every day you're treating 10 or 15 or 20 patients of TB, unless until you are working in a TB hospital. So it's okay to use a reckoner. Thank you.
So very important points Dr. Virinder has highlighted. A new patient who is drug sensitive, that is rifampicin and INS sensitive, is started with this regimen 2 RSZE 4 RHE. And the other thing is that we have dispersible tablets there, and the dispersible tablets which are available, they have variable dispersion because these are as per the WHO recommendation. Because INH and pyrazinamide, it requires acidic medium. So these get dispersed in the gut in the initial part. So the absorption occurs in the duodenum. While rifampicin, it requires alkaline medium. So, all this variable absorption, dispersion, and so the ratio is exactly what is required. That is 1:1.5. And the other last thing which is important is that if you have a child who has got a weight of more than 40 kg, then you need to give adult doses. That is 5 milligram of INH and 10 milligram of rifampicin. And whenever you start ATT, you have to give pyridoxine supplementation, which is now age-based for drug sensitive. That is for children less than 5 years, it's 10 milligram per day. And for more than 5 years is 25 milligram per day. So with this as Dr. Virinder has already said that, we need to extend the treatment for 1 year in cases of neurotuberculosis, where the continuation phase is for 10 months, miliary tuberculosis, disseminated and osteoarticular TB. By disseminated TB, we mean, miliary TB is also in the ambit of disseminated TB, but disseminated TB under the program also includes, 2 separate sites with one normal intervening site. Suppose you have cervical lymph nodes and genitourinary or GIT involvement, and the lung is, there is no pulmonary involvement. So that is what we call as the disseminated TB. So now moving ahead, the same case continued. Now this child, after 1 month, presents again on reassessment, and fever is still persisting. There is no weight gain. In fact, the child has suffered further weight loss. and the chest X-ray shows increase in size of lesions. So there is clinical radiological deterioration at 1 month despite good adherence. Because the first question which any treating clinician would like to confirm is that whether the child was actually taking the tablets or not. So adherence has been ascertained that it was good compliance. So now I'll like to ask Dr. Mattu. Dr. Mattu, what would you like to do next? Now this is a case who is, deteriorated clinically and radiologically. So I believe under the program we have what is called as the integrated diagnostic and treatment algorithm. So would you highlight, take us through that algorithm, Dr. Mattu? Dr. Sanjay Mattu?
Thank you, ma'am. Thank you for this question. So, first of all, a good discussion has already been happened. I would like to first go on the previous discussions when we are having this diagnosis in the pediatric tuberculosis. As Dr. Virender Singh has suggested, all the efforts are need to be made for this microbiological confirmation, right? Best of the efforts are to be made for the microbiological confirmation. We want to have the this thing. Other thing which I would like to say is that when the sample is the precious, as it is in the pediatric age group, when the a sample is also in the small quantity, the upfront net should be the choice of the drug or choice of the test. Sorry. And microscopy, as per the programmatic policy, is what you call is having as a follow-up test only, not the diagnostic test. When we are going with the diagnostic algorithm, we are suggesting that two specimens are to be collected, and two specimens may be from the pulmonary tuberculosis also and for the extrapulmonary tuberculosis also. And one sample is to be sent directly to the net site. It may be the CVNet test or it may be the TrueNet test, which are validated. There are some more net tests as mentioned by Dr. Urvasis B. Singh. And these are still program is finding to put into the algorithm, and we are in process where we want to put in this. But currently it is mainly two tests are there, the CVNet and the TrueNet test, for which devices are to be used for the net testing and confirmation of the Mycobacterium tuberculosis. So other than this, we need to know these along with confirming the diagnosis, they are giving the susceptibility or resistance test to the rifampicin also. Okay. So this net test will give this thing. The second sample is to be sent to the culture DST lab where we would like to do the LPAs also, first line LPA and second line LPA as per need, and then there will be culture based DST testing also to be done. So on the basis of all these things, and we are having some exclusion and inclusion criteria and pre-treatment evaluation. So all will fall in this category, and based on these parameters, we start the regimen, like which regimen is to be started. So after the net, result may come as rifampicin resistance not detected. As soon as this results come that rifampicin resistance has not detected, we have to start this regimen, which as Dr. Virender Singh has already suggested. It is 2 months of HRJD and 4 months of HRE. We are having 3 FDC for continuation phase, where 3 drugs are in the fixed dose combination and ethambutol is separate. Then we are having for continuation phase, it is for 4 months, and we are having 2 drugs FDC, where H and R is there, and ethambutol again is a separate. But as soon as the regimen has been started, we need to do the testing for the H resistance. Okay. Currently, we are having first line LPA for H resistance. In coming time, it may be the pathodetect test or some more test may come, which may give the H resistance also, the test. And as soon as the report is available for the H resistance, we need to see if H resistance is detected. We need to convert the change the regimen to the H monopoly regimen, where this and isoniazid has been replaced by the levofloxacin, and levofloxacin containing regimen, again it is for the 6 months. There are the certain condition where it can be extended to the 9 months. It includes the severe disease, extensive disease, severe extrapulmonary tuberculosis, if there are the uncontrollable comorbidities are there, or if at the month of the 4 the smear is again coming positive. At that time it can be increased to the 9 months. And if H resistance is not detected, we need to continue over the DSTB regimen for the 6 months, and then we have to see if clinical deterioration is still there, as ma'am was suggesting in one case that still there is still improvement is not there and the patient is deteriorating radiologically and clinically, we again has to go to the top of the algorithm, where we again need to collect the sample and again need to do the testing if we are finding some resistance development or those things are there. So again, the top of the bottom algorithm is at the top of the algorithm, we need to follow the algorithm. Once the rifampicin resistance has been detected, we need to see what is the age of the person. If age is more than 14 years, so we the person becomes one of the eligibility is there, the age. So we need to further use the exclusion and inclusion criteria for BPALM. So when the age is more than 14, the person may be eligible for the BPALM along with the other inclusion exclusion criteria. Okay. If person is less than 14 years, BPALM cannot be given because the scientific evidence is the study was not done below 14 years. So that is the criteria. In those cases, and where the BPALM is not eligible, the person will be next choice of the regimen will be the shorter oral regimen. And in shorter oral regimen, you can understand earlier there was the ethionamide was the drug, which was the part of the intensive phase. So intensive phase, we are having 7 drugs are there along with the bedaquiline and including bedaquiline. But ethionamide now has been replaced by the 2 months of linezolid. You can see in the bracket, it is 2 months of linezolid is there, which is there in the intensive phase. And in the 5-month continuation phase, we are having the 4 drugs where the levofloxacin, clofazimine, pyrazinamide and ethambutol should be continued. Again, it is a 9 to 11 month regimen. When you have to increase the 9 to 11, so again at the month of the 4, you will see smear microscopy. If it is coming positive, then you can increase 1 more month, and if it is coming at the end of 5 months also, you can increase for 1 more month. So that is how you are increasing to the 11 month. Then last regimen is the all oral longer regimen, where we are having this 5 drug regimen is there along with the bedaquiline, which is given to be given for the 6 month or more month as per the discretion and decision of the clinician. And then 18 to 20 month we are having this levofloxacin, linezolid, and we are having clofazimine and cycloserine. So these are the drugs where we are giving to this longer regimen. You can understand this is the last choice of regimen. If any of these 5 drugs is not fitting, either because of the previous exposure or if there is a resistance, then we are having a group C drug which are used for the replacement. Okay. And you can understand in children, when we are having children age group, you can understand the bedaquiline is not available in India below the 5 year. So because of this, in the shorter oral regimen, we are using instead of the bedaquiline, the injectables are to be used to make a shorter oral regimen where amikacin and kanamycin may be used. And in longer oral regimen, because bedaquiline is not available in less than 5 years, so whenever the longer oral regimen is to be given in less than 5 years, we have to go by the replacement sequencing. And you can understand delaminate is the first choice among the C group or C category of the drugs. And so delaminate makes the longer oral regimen for the less than 5 years. So this is the algorithm which we are using as of now. And so these were some of the clarification. And another thing, IGRA test and SciTB tests were done. So I would like to highlight here, like IGRA and SciTB tests are to be used for infection detection, not a disease. They alone cannot be used. They may be supportive, as Dr. Vrinder Singh has suggested, that many times bacteriological confirmation is not possible, and many times we have to go by the radiological diagnosis. So in the radiological diagnosis, this SciTB and IGRA test and the epidemiological history can be supportive for making the diagnosis. So this was about to the algorithm, ma'am, from my side. Over.
Thank you, Dr. Mattu, for taking us through this very complicated but easy to understand. I mean, you have clearly highlighted that there are 2 parallel wings which go depending upon the rifampicin sensitivity, whether it is rifampicin sensitive or not. If it is rifampicin sensitive, then you have to further look you start the RSZE regimen and further look for INH resistance. If INH resistance comes, then you just replace, then you need to restart the new regimen by replacing INH with levoflox or moxiflox, as the case may be. And now coming to if rifampicin resistance is detected, then if the age is more than 14 years, so that is one universal regimen which is being preferred all over the world. That is the BPAL M or BPAL regimen. That takes care of all cases of rifampicin resistance, even FQ resistance. And if the child is not eligible, as are our children, because our children they have um, the age criteria along with, because if the child is not more than 14 years, then the child is not eligible for BPAL. Then we have two choices depending upon the severity of the disease. If it is a non-severe RR or MDR, then we have the shorter DRTB regimen, which you have already shown. And for all other, that is severe cases of by severity, these are the criteria which are written in the box below. That is, non-severe TB is defined as pulmonary TB or intrathoracic TB, which is smear and or culture negative, but it can be culture positive, but it with or without NAT positive. That means NAT or culture can be positive, but smear has to be negative, and the lesions, they need to be confined to less than one lobe with no cavities. As in our case, there is one cavity there, so it's automatically a case of severe pulmonary TB. And there should be, if there is pulmonary pleural effusion, it should be uncomplicated. That means it should not have thickening or loculi. And if there is mediastinal lymphadenopathy, it should not be causing any obstruction. And there should be no mill remodeling. So this is a non-severe intrathoracic or pulmonary TB. And extrapulmonary TB in children, there is only one category which fits into, that is peripheral lymphadenopathy. That's a difference from adults. For adults, all extrapulmonary TB like GIT, genitourinary, except osteoarticular CNS TB or Milry, now Milry is defined in pulmonary TB. These fit into. Rest all extrapulmonary involvements are non-severe, but for us in pediatrics, all are severe category except peripheral lymph node. And if there is a non-responder, that means a presumptive DRTB case who is found on repeat DST to be rifampicin and INS sensitive, then you don't need to continue the regimen, you need to restart that regimen. This is another important point, that you need to restart your DSTB regimen. So with these words, now let me come to the status of these regimens in India. WHO has approved all these drugs, that is the DRTB drugs, to be used for all ages, but we are still struggling with the approvals. In India, Bideclan can be used for only those children who are more than 5 years and 15 kg, while Deliminate for all ages, but the weight of the child has to be more than 10 kg. So for small children, we are still forced to use injectable regimens, especially if the child is less than 10 kg and requires a longer or a shorter TB regimen. So now coming to a case further, now this is the child who is experiencing clinical radiological deterioration. As you can see now, there are the chest X-ray, the lesion has increased on the right side, and also there are there is a patch which is developed on the left side also. So now I like to ask Dr. Vrinder, these are the sputum reports which have emerged now. Now, the initial RS sensitive patient, on repeat sputum smear examination, sputum status remains 3+, and now it is rifampicin and INH resistance on first line LPA. And on TrueNAT, it is rifampicin resistance, but luckily the child is FQ and SLI sensitive. So, what would you advise in this child?
So this is a child who now has an MDR, thankfully fluoroquine sensitive MDR, but it is a severe PTB because now by cavity and that too bilateral. So therefore, this is a child who will go on a longer regimen. So longer DRTB regimen, that's what this child would require. All oral longer regimen, which will have bedaquiline, which will have linezolid, which will have levofloxacin, clofazimine, and cycloserine. Unless until the child has been exposed to any of these drugs for more than 4 weeks, then that's a difference. So sometimes they earlier has been treated as pyogenic with linezolid for a long time. There may already be an exposure. So those situations you may have to remove that drug. Thankfully, fluoroquinolone is a drug which is more often used, and here we have a sensitivity to fluoroquinolone that helps. So that is what would we recommend.
Or in such situations, where linezolid has been used prior, you would like to check the linezolid sensitivity status to be sure that linezolid will be effective. So, as Dr. Virender has clearly highlighted, the child should be started on long all oral regimen because the child ages 7 years and the weight is at present 16 kg. Because more than 5 years and 15 kg, the child can be given bedaquiline that makes the child eligible for all oral longer regimen. And not another very important thing which is there is when your child is not improving, you need to go ahead with the HIV testing and blood sugar. Over here, the blood sugar also is 186. So you need a good glycemic control. Only then your TB will improve. So that is another very important point which needs to be taken care
But
of.
that's an unusual scenario. No, most of the time
Yeah,
we do not
but you have,
raise blood
in
sugar.
this child,
Yeah,
the
I
child
agree. If
had,
it is raised, then it has to be.
yeah, undiagnosed diabetes. So but the blood sugar came 186 because
One
the
of the
child
things
was
which I
not
forgot to
improving.
mention, Dr. Sharma, sorry, I'm interrupting you, is about pyridoxine. Because the moment
Yeah,
we talk of cycloserine and other drugs coming, pyridoxine becomes an important component both for drug sensitive and drug resistance. And that you already alluded to the doses earlier. I
yeah.
see Dr. Mattu has raised hand.
So just to add what you have said, like in this case, it is a bilateral lung disease. So shorter oral regimen cannot be given. Extensive disease, whereas longer oral regimen is the choice of the treatment here. And one more thing, we are having, as you suggested, the history of exposure. Still, the choice of regimen will be the longer oral. Only the replacement will be done as per the sequencing which are there. So this is one thing. Other thing is like it is a extensive pulmonary disease, so shorter oral may not fit, but if the age would have been, in this case, more than 14 years of age, then the choice of regimen would have been the B-palm, because in the extensive pulmonary tuberculosis also, if age is more than 14, the B-palm can be given and a longer oral regimen will not be choice. But shorter oral cannot be given in more than 14 also for the extensive pulmonary disease.
So that is
Just
very
wanted to add
important
this.
point
This
which is
could be.
emerging. Yeah,
Yeah.
that
That's right.
BPAL-M
If the child
can
was
be
more than
given
7.
for severe pulmonary TB, except for TBM or CNS TB and miliary TB. Rest, BPAL-M is the regimen of choice for children who are more than 14 years of
14.
age.
Yes, ma'am. Yes.
So now moving next, the lessons which are learned, if you have a poor responses, always ask these questions, whether it is the disease is microbiologically confirmed or clinically diagnosed, and what is the DSTB pattern, as in this case, it is rifampicin and INH resistance with severe more than one lobe involvement with a cavity. So all these and if there is a comorbidity present or not, especially the three comorbidities. One is diabetes, HIV, and malnutrition. The child is also malnourished, and there is a history of TB death in the family. So all these questions they need to be asked before deciding on the regimen. So this is in nutshell what we had discussed about the treatment part. So the child was started on all oral longer regimen for severe MDR TB. So now we move on to the last very, very important topic, that is who to give the prophylaxis, that is the TB preventive therapy or to start ATT. So quickly, I would like to ask my colleague Dr. Varinder Singh, this is a mother who is recently diagnosed with drug-sensitive TB. She is sputum 1 plus, and luckily she is RH and FQ sensitive. So she has 3 children. One is 2-month-old who is thriving well, is asymptomatic. This is the chest X-ray. The second is 4-year-old thriving well, asymptomatic again, and the TST is 2 millimeter. The third child is 7-year-old thriving well, asymptomatic. CYTB skin test done over here is 3 millimeter, and the chest X-ray is normal. So, what would you advise? In all these 3 scenarios?
So, essentially, below 5 years, first of all, you have to rule out disease before you think of a preventive therapy. So, ruling out disease, one could be a symptom screen, whether the patient has any symptoms, is symptomatic at all. Sometimes there can be a primary asymptomatic disease which is still not coming up. So, if the facilities are there, one may do an X-ray, but that's not mandatory. That you should not hold back a TB preventive therapy because an X-ray cannot be done. If it can be done, fine, you can definitely rule out a disease. Otherwise, asymptomatic with X-ray disease is not so common. So below 5 year, if there are nothing to suggest a disease or you are ruled out by doing a X-ray, and if the X-ray had a lesion, then obviously it takes the disease path. Then you can assume without doing a tuberculin skin test, without doing an IGRA, that this child is infected because it's a close contact within the family with an open case. So therefore, in these situations, you will start 6 months of INS. That's our primary therapy. An alternative thing which is available is 3 month 12 dose HP, but as yet we have not started giving below 5 years. But it's recommended by WHO for 2 years plus. That's an alternative. But our primary drug for TB preventive therapy in the country is, as of now, 6 months of INH with pyridoxine supplementation. If this child is above 5 years and this child has no symptom, is thriving well, then if you test, you can first offer treatment. They can take treatment as it is for preventive therapy, or they will say, I'm not sure whether I'm infected or not. You do a test. If the test is negative, the child is not infected. You may not give TPT. But if the child is positive, any patient above 5 years, if it's positive for TST or IGRA, whatever you use, is then has to be offered a TB preventive therapy because it's very effective. Below 5 years, we usually do not test because there is some effect on the sensitivity of both CyTB and tuberculin below 5 years. And as it is, they are close contacts and therefore they are more at a risk of getting infected. And younger the child, more is the risk of dissemination or transmission. Transition from infection to disease state happens faster in younger children. And therefore, in younger children, you will initiate TPT and not decide based on a CyTB or a tuberculin skin test or an IGRA. While in above 5 years, if you can do test, fine. If you can't do test, then also you can offer TPT, provided the disease is ruled out, either on the basis of symptom screen or investigation.
So, very important, Dr. Virinder has highlighted. I think we have already gone through this algorithm that we ask symptoms. If the symptoms are there, then you investigate to rule out the disease. If the child is less than 5 years, more than 5 years, you can offer a test and treat policy. That is, you can offer the CYTB skin test, and if it is positive, then give TPT. So important thing is that you need to rule out active disease and follow up for active TB as necessary, even for patients who have completed TPT. That is another very important message. And routine pyridoxine supplementation has to be given to all children who are initiated on TPT or ATT. So this message needs to be made clear that be it ATT or be it TPT, pyridoxine has to be given. The doses are different for different regimens like drug sensitive and drug resistant. And also airway infection control. as in that child is just 2 months, so the mother needs to continue breastfeeding using a face mask till she is sputum smear positive or culture positive, because that is very important, and proper sputum disposal and cross ventilation, neither to say, because these are very important aspects which are often neglected by our patients. So these needs to be stressed upon. So regarding the regimens which are available right now, we have these regimens for drug sensitive, that is INS 6 months regimen, that is given daily, even for all ages for children with HIV. The 3 HP regimen has been rolled out in our country for children who are more than 2 years, although WHO has recommended for all ages. Now coming to 1 HP, 1 HP regimen is for those situations which are emergency situations, like a cancer patient needs to be started on cancer therapy, or there is an organ transplantation which is pending, so you need to have a rapid prophylaxis. In those cases, you need to give daily 1 HP, but still we are not using in our country. And WHO is doing validation studies for children less than 2 years on 1 HP regimen. Now coming to, if there is INH monoresistance, the regimen which needs to be started is 4-month daily rifampicin, and if it is MDR, then it is levoflox or moxiflox, 6 months daily regimen. The 3 HP regimen is a weekly regimen, total 12 doses, so 3 months of weekly doses. That is the regimens now which have been rolled out. So we have 6H for small children, 3 HP for children at present more than 2 years, and 1 HP for children more than 13 years. And routine pyridoxine supplementation. And as I've already said, that chemoprophylaxis is one of the most important thing. If you have a contact, do active contact tracing. Always when you diagnose any child, or there is an adult in the family who is sputum positive, or a child is sputum positive, all the siblings, the contacts, they need to be notified in the Nikshay portal, so that the Nikshay can do the rest for the family. So with this, I would like to end our panel discussion over here. And I would like to thank all my panelists for such a wonderful discussion. I think we overshot the time, but the organizers were patient with us, because it was a very fruitful discussion, and all the panelists, they are luminaries in their own right. So nobody had the guts, even me, to stop them. So with this note, I would now like to pass on back to the organizers, please. Thank you so much.
May I add something before?
I would also like to add one thing.
Just
Yes, please.
1 minute. I will take. So, ma'am, you have already very well explained, and Dr. Vrinder Singh have explained the TPT. Only one thing, like whenever the site TB or the this IGRA is positive in more than 5, also we need to rule out the active TB cases. So we have to do the X-ray and the NET testing also. And if they have been ruled out, it was very well highlighted by Dr. Vrinder Singh also. So this is one point I would like to highlight. Other thing is, like nowadays we are having HP combinations. The isoniazid and the rifampicin is the choice of the TPT, TB preemptive treatment, because it is for 12 weeks. In the when we are having 3 months, and then 1 HP, as has been suggested. Usually we are preferring, as you have categorized in the cancer, other those things, but along with that we are preferring in the CLHIV, the children who are having the HIV infection, because each of they are taking the daily medications. Weekly medication is not feasible among them, and this 6H usually is to be preferred in the less than 2 years only, because HP is not allowed in the less than 2 years. So these are the some things which I wanted to add in the TPT part. And there are some more things from the program, like to find out, our theme is we want to find out all the cases. We want to treat each and every case as per the standard regimen, and then prevention also. Prevention we have discussed. For finding out all cases, we have increased the symptoms of the presumptive TB from 4 to now it is 10. And it was
Absolutely. This
yourself
is what
and
Dr. Matu, let me deal with this.
yeah,
So,
yeah.
yeah, this was what we rolled out in addition to the WHO 4S. We rolled out 10S for the adults, and then for 10S for children as well, with with help from several of our pediatrician experts. Dr. Sangeeta, I would like to speak about the 10S. This
Yes,
was
please.
an
Yes,
initiative we
surely.
took in 2025. Yeah, please.
Yeah. Tennis and the red flag signs also, which we have come up with.
Yes,
for
that is also very
pediatric-
important so that our, our pediatricians in the country are aware.
So, uh,
Dr.
should,
Sangeeta, आप बता रहे हैं?
should I
Are
read
you
out?
covering the?
I
I'm
think,
having these
sir, you
10 as
read them out, please, because
I'm having.
yes,
So, like
because the
one is the
order of
persistent.
importance is the order in which we, finalize them. That is most important.
So
Yes.
the idea was to bring in early signs and symptoms, which the common man and the general public they need to be aware of, so that early signs of a disease which can strike, it can take several years to strike. That was the idea of expanding. It is not any out of the world signs, but nevertheless we made it into 10 symptoms very clearly for adults and children. Dr. Mattu will share that with you.
So it is first symptom is the persistent cough for more than 2 weeks, then unexplained fever for more than 2 weeks. If there is failure to gain weight or obvious weight loss is there, if we are having loss of appetite, poor food intake or refusal to feed, this is the fourth symptom. Fifth is the fatigue or reduced activity or playfulness. Sixth is the breathlessness. Seventh is the chest pain, breathlessness. You are the pediatrician, so they are the respiratory rate for breathlessness. Like if less than 2 months, more than 60, 2 to 12 month, more than 50, 12 to 60 month, more than 40, and more than 5 year, more than 20 is the respiratory rate. Chest pain is the seventh symptom. Blood in the sputum is the eighth one. Ninth is the night sweats. And then symptoms of the EPTP, like nodular swelling in the neck or any other sign and symptoms of the extrapulmonary a disease. So these are the 10 symptoms which we have included. Other than program is advocating not only finding out this in OPDs but also IPDs also, because in bed patients, if they are screened, that is also one recommendation from program. Please, whenever you are having the IPD patient admitted for non-TB, please have these 10 symptoms also. Another thing is the program is also looking for the asymptomatic TB in the vulnerable category of the persons, and same applies to the children also, like diabetic, HIV children, or if there is the active history of the contact or the past history of the TBs are there. So these are the some of the category which apply for the children also, if they are remaining some urban slums or the tribal areas. So in those, if even there are no symptoms, we are suggesting that annual X-ray screening can be done, and we are nowadays having this digital hand X-ray which are having very low radiation, which can be safe in the children also. This was the another thing we are recommending from the program side. And another one more point last, like we want to have not only ATT, we want to have the differentiated TB care. So differentiated TB care means that along with the TB treating tuberculosis, we need to treat it the complications of the tuberculosis also. We need to treat the comorbid conditions. One of most common is the undernourishment, which already DDG has highlighted, which are the certain things program is looking for. Other than this, it may be diabetes, HIV infections, or ADR reactions also, the adverse reactions which are the also need to be taken care of. And then there might be some other suggestive complications as per the expertise of the treating pediatricians. So differentiated TB is the other thing. And as suggested by Dr. Sangeeta Madam also, there are the again some differentiated TB care not only at the health facilities. We are recommending identification at the community level, at the family level. So 10 red flag criteria has been developed for the families. So if a forum is allowing, I can read out these 10 red flag criteria for families also, which they need to identify and can take the patient to the health facilities. And also please provide the beds. Whenever the patient needs the admission, most of the time it is difficult that the TB beds are not available in the wards. So if you are allowing, I can read out these 10 red flag criteria also, if we may share
Yes,
through
sir.
the IAP forum also. Over to you.
Please fast पढ़ दीजिए.
Yeah, one is the patient is confined to bed. Fever is the thing. If the person is having high grade fever and diagnosed case, he may need to be admitted. Breathlessness, we need to explain in the common man's language, like if it is a breathless at rest, difficulty in speaking or unable to complete a sentence without pause. The child is unable to take the feed or unable to walk 10 to 15 feet, and he has to sit in between, cannot make a this perform the natural calls, cannot go to the washroom or those things. Then if there is a bluish discoloration of the lips or fingers, severe pain in the chest or abdomen, hemoptysis, altered consciousness, convulsion, limb weakness, recurrent vomiting or diarrhea, or if there is a severe loss of weight, or sign and symptoms which are suggestive of the adverse drug reactions. These are the red flag criteria which need to be looked at every level, at the health facility assessment is done, and at the family level and community level also. Sorry, I'm also have taken longer time, but these were the some of the important messages which I need to disseminate over this forum. Thank you very much.
And I would also suggest, Dr. Sangeeta, that these messages, if they can be actually communicated in writing, these we initiated last year, all these new things that Dr. Mattu just shared with you. But we will really urge IAP if this can be disseminated widely through your association, please.
Definitely.
I think that's very important, ma'am, what you have said, that these need to be sent across to the pediatricians.
Sure, ma'am. Thank you so much, ma'am. Thank you. It was a wonderful, very enriching session today. And as we come to the end of this session, I must admit that this was very extensive, comprehensive, yet very understanding to us. To a common general pediatrician, it was like a guideline for us today to understand the things so well. Now I request Dr. Alok Bhandari, sir, for the vote of thanks.
I will request our president, Dr. Neelam Mohan, to say she wanted to say something.
No, I wanted to say Ruchira is there, or she's in the other program today. She was in the vaccine program. So if she's there, she can give the vote of thanks, and otherwise Alok ji and Dr. Ruchira was busy with
Dr. Urushi and Dr. Mattu had requested for unequivocal commitment from IAP, which you had already done.
No, I gave it in the beginning.
And at the end also,
you all ended, I'm very fast, my problem. I've already formed a committee. And there are some names and everything. I'm very fast. So all that has been done. So you will get the messages from the committee in the next 3 weeks, what we want.
So Dr. Neelam, as our DDG also highlighted, we need your support for our monthly eco session, the pediatric.
Yeah, that we will have to just, Alokji, can I give you this responsibility to connect with her, get the date, and I'm preparing the draft with the committee. So in that, we will write this to the date and time. So if he forgets, then you connect me.
Yes, okay.
If he forgets, and don't miss it, Alokji, please.
Dr. Sangeeta, you are fully authorized to take any decision on behalf of IAP, and it will be a pleasure for us.
No, but we will have to message it. She does a eco clinic. I visited on it as an expert last year, but I think it's a good one. We will send email to everybody.
Because all our pediatricians, they are free to present their cases, because it's a to and fro learning platform, where we want involvement of all our pediatrician colleagues.
Great, that will be
learn
beautiful.
from each other.
Dr. Varinder also wants to say something. Dr. Varinder ji, boliye, please.
I know this has been a time for the program to ask IAP to do something, but I think IAP also has an ask from the program. With the support of the program and IAP, a lot of trainings of the pediatricians were done, and those modules were taken, and we all have done that for nearly a decade. Those need to be brought back into
for that,
focus,
we will talk
and
to
there is
Matuji. There
also
was
some
something.
pending issues regarding that, which
Yes.
I would suggest that they should be clarified at the earliest.
Yeah,
And
that's
we
why
should
I
go
said
ahead
Matuji that I'll
with
come
further
and meet him.
training.
I'll go and meet
Yes,
for
sir,
that.
we will take it up. We will take it up.
either myself or one of our, team members. I've already noted this, and that's what I have written to Matuji, because we need to work together for our nation.
I would like to reassure Matuji and Shobani madam that I myself was a CHS officer, interacted with Matuji when he was at the Airport Health Authority days also.
So sweet.
And then Anurag Agarwal is a CHS officer, professor at Maulana Azad. And our another EB member, Dr. Mukesh Dhankad, is a professor at Lady Harding. And Surinder Bisht, another EB member, is also senior specialist at MCD. So we have, who is also handling tuberculosis day in and day out. So we have ground level CHS and service doctors as our influential EB and OB in the IAP, and we assure you that we'll take it forward, and you'll not find IAP lagging behind in our goal for TB eradication.
Thank you so much.
Thank you.
Big thumbs up.
Thank you.
And-
Bye-bye.
Bye.
To everybody. Thanks.
you.
And I
Thank you very
also
much.
thank you all on behalf of Ruchira. She's in the other meeting. So thank you so much, Sangeeta and Virender ji and all the EBs who've been doing it. And a special thanks to Matuji, Urvashi madam. Thank you so much. It was lovely meeting you digitally, Sanjay ji. And I look forward
you.
to having a cup of tea or coffee in your office when you invite us. Thank you.
Thank you, ma'am. Thank you.
Thank you.
Sure.
Thank you.
Thank
Cheers.
you. Thank you.
Thank you.
Thank you.
Thank you.
Thank you. Thank you.
Thank you, Devender ji. We missed you in the beginning. Thank you so much. Thank you. He's our Vice President, North Zone, doing a lot of work. Ajay Arora is also not EB. Thank you so much. Oh, Chaudhary sir, always there. Really from UP, one man who stands like a wicket keeper, goalkeeper. Thank you.
Ajay Arora,
Thank you.
sir. Ajay is the.
Thank you,
Yeah, I
ma'am.
said Ajay ji. Ajay, I said not Arora, but Ajay. Thank you so much. Shobani, that was really very sweet of you. Thank you for giving your time.
Thank you.
And
Thank you for
everybody,
your
Dr.
guidance.
Ramakrishna and Nirupama, Rohit, and everybody, thank you so much. And bye-bye. Have a wonderful day today. And we meet with the message of learning from masters from Ganesh, which he will post you in the group. Thank you. Good day.
Thank you, ma'am.
Thank you, ma'am. Thank you.
अच्छा जी आलोक जी भाजी
Okay, bye, ji, bye, sir.
भाजी
Bye. Okay, Dr. Shobni ji, bye, bye.